AVN hip long case history taking. 1. Patient introduction and consent. The first thing you must do is introduce yourself to the patient. Tell them why you are here and what you will be doing. Always obtain their consent before starting. This step builds trust and rapport. Also, ensure that the patient is properly exposed for examination, but remember to maintain their dignity at all times. 2. Patient details. Start with collecting basic information about the patient. Name, age, gender, occupation, marital status, address. These details help establish the patient profile and provide context for understanding the condition. For instance, AVN is more common in younger adults and can affect their ability to work or perform daily activities. 3. Chief complaints. Ask the patient about their primary problems. Usually, they may report pain in the hip. Note the duration, for example, 5.5 years. Limping, again, document the duration, for example 3.5 years. Be precise and use the patient's own words whenever possible. 4. History of present illness. Now, dig deeper into the current complaints. Start with a timeline of events. For example, the patient was completely normal 6 years ago. An accident occurred. Ask about the mechanism, for example fall from height, road traffic accident. Details of the injury: sustained a closed fracture of the neck of the femur. Early management: reached the hospital within 4 hours, was resuscitated, and underwent surgical fixation with cannulated screws. Also, discuss the postoperative recovery. Initial care, including non-weight bearing and physiotherapy. When did the pain start? Dull aching pain began 5.5 years ago, gradually worsened, especially with weight bearing. Progression of limp, like gradual onset over 3 years, now requiring aids like a cane. This step gives you a chronological understanding of the condition. 5. Associated symptoms. Now, rule out other possible causes. Ask about fever, night cries, weight loss, anorexia, or morning stiffness to exclude infections like tuberculosis. History of joint pain, swelling, or stiffness to rule out inflammatory arthritis. 6. Nutritional and treatment history. Assess the patient's nutritional status and any past treatments. Ask about their general diet. Poor nutrition could worsen bone health. Document any previous surgeries, medications, or functional limitations, like difficulty in activities of daily living. 7. Past history. Check for significant medical or surgical history. Specifically ask about steroid use. Prolonged use of steroids is a major risk factor for AVN. Unverified or herbal medications. 8. Systemic review. Investigate systemic conditions that may contribute to AVN. Autoimmune disorders like SLE, liver dysfunction, hyperlipidemia, or hyperuricemia. 9. Family and personal history. Ask if there is any family history of genetic disorders. In personal history, focus on alcohol consumption, chronic use, smoking or other habits. 10. Socioeconomic status. Understanding the patient's socioeconomic background is important. It helps in planning treatments that are affordable and realistic for them. 11. Allergy history. Always check for any allergies to drugs or food. This will influence the choice of medications and anesthesia if surgery is required. 12. Patient expectations. Finally, discuss the patient's goals and expectations. Are they hoping for pain relief, improved mobility, or the ability to return to work? Knowing this helps you plan a patient-centered treatment strategy. By following this structured format, you can systematically gather all relevant information. Remember, history taking is not just about asking questions, it's about understanding the patient's story. Always be empathetic, listen carefully, and tailor your approach to the patient's needs. This comprehensive framework will help you excel in both academics and clinical practice. Examination for AVN hip long case. 1. General physical examination. Start by evaluating the general physical condition of the patient. Here's how. Patient profile. Assess the overall appearance of the patient. For example, you might see a young male with an average height and build who is conscious and oriented to time, place, and person. The patient should be comfortably lying supine during the examination. Vitals. Take measurements of pulse, blood pressure, temperature, respiratory rate. Look for signs like clubbing, especially in the hands, muscle wasting, pallor, jaundice, or cyanosis. Check the eyes, ENT, lymph nodes, thyroid, jugular venous pressure, and presence of edema. 2. Systemic examination. Perform a detailed systemic examination. Chest examination. Inspection. Look for symmetry and any deformities. Palpation. Check for tenderness and chest wall movement. Auscultation. Listen for normal breath sounds and any added sounds, such as crackles or wheezes. Chest expansion. Measure and compare both sides for any restriction in movement. Cardiovascular system. Inspection. Check the chest shape for any abnormalities like precordial bulges. Palpation. Feel for the apex beat and check for heaves or thrills. Auscultation. Listen for heart sounds, S1 and S2, and murmurs. Abdomen. Supine. Look for scars, distension, or pigmentation. Standing. Assess for any spine deformities. 3. Local examination. Now, focus on the local examination of the hip region. Standing. Observe for pelvic tilt and compensatory spinal curves. Deformities like a shortened right lower limb, external rotation of the hip, heel off the ground, and ankle in equinus are common. Look for wasting of thigh and leg muscles, scars around the hip or any skin changes, like trophic ulcers, presence of assistive devices, such as ankle-foot orthoses or crutches. Gait analysis. Check for a Trendelenburg sign, which indicates weakness of the hip abductors. Short limb gait, where the patient tries to compensate for leg length discrepancy. Functional tests. Squatting, look for knee contractures or equinus deformity. Sitting cross-legged, assess for hip contractures. Spine screening, look for café au lait spots, tufts of hair, dimples, or scars, which may indicate a spinal condition associated with hip pathology. 4. Screening examination. Examine the spine and upper limbs for any related or contributory conditions. Spine examination. Look, observe for deformity, alignment, or skin changes. Feel, palpate for bony tenderness or step deformities. Move, assess the range of motion of the cervical and dorsal-lumbar spine. Tests, perform Adams forward bend test and Schober's test to evaluate spinal mobility. Upper limbs. Look, feel, move, check the range of motion of the shoulders, elbows, wrists, and hands to assess for any associated conditions like stiffness or contractures. 5. Palpation, on supine. Now, let's palpate while the patient is lying supine. Temperature. Ensure there is no local rise in temperature around the hip joint or affected limb, as this could indicate an infection. Tenderness. Palpate over bony prominences, joint lines, and scars to assess for pain or tenderness. Soles. Check for ulcers, callosities, or corns that may be present due to altered gait. Lymph nodes. Palpate regional lymph nodes to rule out lymphatic or metastatic involvement. Graft sites. Inspect for any issues or complications at donor sites if previous surgeries have been performed. 6. Range of motion. Assess the range of motion in the hip joint and related areas. Active ROM. Evaluate the hip, knee, ankle, subtalar, mid-tarsal joints, and toes. Identify any restrictions in movement, particularly internal and external rotation of the hip. Passive ROM. Perform during the Thomas test to assess for contractures or limitations in movement, particularly internal and external rotation. 7. Special tests, on supine. Several specific tests are used to assess hip function and any underlying issues. Hip tests: straight leg raise, sectoral sign, Thomas test, telescopy test, Erickson, Fader, Faber, and Delitzzi tests. Measurement tests: measure limb length discrepancy using methods like Bryant's triangle, Nelaton line, and Shoemaker's line to assess for leg length differences. 8. Neuromuscular examination. Assess the function of the nervous and muscular systems. Pulse: check the vascularity of the limb to ensure adequate blood flow. Sensation: test dermatomes and, if impaired, perform Tinel's sign to assess for nerve involvement. Tone: check for hypertonia or hypotonia in the muscles. Power: grade the power of all major muscle groups on a scale from 0 to 5. Reflexes: test deep tendon reflexes to assess the integrity of the spinal cord and peripheral nerves. This comprehensive approach ensures you are thorough in your examination for AVN of the hip. Remember, each step is important in understanding the severity of the condition and how it affects the patient's quality of life. Be systematic, precise, and patient during the examination, as this is key to making an accurate diagnosis and planning appropriate treatment. 5 questions and answers for AVN hip case. 1. What is your diagnosis? The diagnosis is osteonecrosis of the femoral head, commonly known as avascular necrosis. 2. Why AVN? You'll need to justify your diagnosis with the following points. Gradual or spontaneous onset of pain, often with no specific injury but a slow progression of symptoms. Pain-free period following trauma. Some patients report relief from pain initially after an injury, but the pain eventually returns. Ability to bear full weight initially after trauma. The patient may manage weight bearing initially despite the injury. Slow progression of symptoms. Over time, symptoms gradually worsen. Supratrochanteric shortening, noticeable shortening of the limb above the hip joint. 3. What is your differential diagnosis? Several conditions can mimic AVN, so it's important to differentiate them. Non-union of neck of femur. Persistent pain and difficulty in weight-bearing post-trauma. Painful limping, tender inguinal region, externally rotated limb. Positive Thomas test and telescopy, but negative Trendelenburg sign. Tuberculosis of the hip. Symptoms include fever, anorexia, night sweats, weight loss. Early painless restriction of motion that later becomes painful. Global motion restriction, which may progress to ankylosis. Pyogenic infection. Fever, discharge, redness, and pain, often with a toxic presentation. Could lead to ankylosis or hip dislocation. Tumor. Features include weight loss, night pain, and systemic involvement, which can indicate malignancy. Implant-related issues. Implant cutout or failure, presenting with pain and instability around the hip. 4. How will you proceed? The next step is to confirm the diagnosis with imaging. The key investigation here is radiographs. Pelvis X-ray and an anteroposterior and lateral view of the affected hip is essential to assess bone quality and femoral head changes. 5. What would you like to see on the radiograph? Look for the following signs. Bone quality. Check for reduced bone density or any osteopenic changes. Femoral head. Look for radiolucencies, loss of sphericity, or collapse of the femoral head. Resorption of the femoral head and neck. Joint space. This could be normal, narrowed, or ankylosed or fused. Acetabular margins. Watch for sclerosis, narrowing, or osteophyte formation. Implant-related issues. Check for radiolucency around implants or signs of failure, like cutout or fractures. Signs of infection. In the absence of infection, the acetabulum and joint space should appear normal without lytic lesions. 6. What would you like to do next? Next, consider the following. MRI. MRI is essential when X-ray findings are doubtful. It is especially useful in suspected cysts or for planning osteotomy. MRI can also help in evaluating the contralateral hip in non-traumatic AVN cases for preventive measures. Keep in mind MRI compatibility. Titanium implants are MRI safe, but stainless steel is not. Baseline laboratory investigations. Perform a CBC, CRP, and ESR to rule out infection. Other imaging. CT scan, useful for assessing non-union or malunion of fractures. Bone scan, can help differentiate AVN from tumors or infections but cannot distinguish between tumor and infection alone. 7. Which classification is used for AVN of the femoral head? There are several classifications used, but the most common are: Thicket classification, the most widely used classification for AVN of the femoral head. Other classifications include Modified Thicket, Association Research Circulation Osseous, Steinberg classification. 8. What is the difference between traumatic and atraumatic AVN? Atraumatic or idiopathic AVN. The lesion is usually located in the anterosuperior region of the femoral head. It is typically bilateral. Traumatic AVN. The entire femoral head is usually involved, and it is often unilateral. Traumatic AVN is commonly caused by a direct injury such as fracture dislocation. 9. How will you treat this patient? Treatment will depend on the stage of the disease and patient factors. Here's a breakdown. Counsel the patient. Discuss factors such as age, occupation, financial status, and comorbidities before deciding on the treatment plan. Management options. Non-operative, like in early stages. Restrict weight bearing to prevent further damage. Physiotherapy to improve mobility. Bisphosphonates or anticoagulants to slow the disease progression. Operative, like in advanced stages. Cord decompression, indicated for early AVN, stages 1 to 2. Osteotomy, considered if deformity is present. Total hip arthroplasty, the treatment of choice for advanced AVN, stages 3 to 4. Other options may include bone grafting or vascularized fibular grafts. This structured approach to AVN in the hip should provide clear and concise answers during your viva. Be sure to tailor your responses based on the examiner's focus, but always remember the key points of diagnosis, imaging, and treatment options for AVN.